Evening, friends, colleagues. Welcome to this webinar about this Sino-US against this COVID-19. All of you can hear me, right? Thank you very much.
That's good.
Join the meeting, and we shall also thank Broncus to provide the platform so we can discuss, share our opinions, and to win the war against the COVID-19. This is really harder to all human races. And first of all, we have a bunch of good speakers today. And first of all, I would like to invite Professor Zhongnan Shan to give the opening speech. I guess Professor Zhong does not need any introduction. He is a leading figure in the war against SARS and in this war against COVID-19. And without further ado, let's welcome Professor Zhong to give the opening speech, followed by his talk on strategy for anti-COVID-19 in China. Professor Zhong, please.
Okay. So, good evening, everybody. So, thank you very much, Dr. Lam. And so, I just came here. So, you want me to say a few words and then start my presentation, is that right?
Yes, please.
Oh, thank you. So I think that now the problem seems to me, here we are in the morning. So I watched the TV. I think some of the countries seems to be going down, like in Italy, and I think in Germany and France. However, the situation is getting worse in Spain, in particular in the United States, which is I'm very much concerned about the rapid increasing of the patients' number in the United States, which is about more than 80,000, as higher than that in China. So the first. So I think that we need to be very much aware about how can we control that effectively. So this is why Dr. Lam and some of my U.S. colleagues and we really would like to have a change of our experience and our lessons from each other. So we start this meeting. I'm very happy to have to share with you our lessons, or sometimes I can say experience. So I suppose I should start the talk. So the talk of my yes. So and I think in the next 30 minutes, I would like to talk some outline of the China status in combating SARS, coronavirus infection, COVID-19. So as you know, this is the data and this morning, and of course in the United States in evening. So altogether in the world, so more than 500,000 people infected, and the mortality is 1,000. That's 4.5. Fortunately, the mortality in the United States is not that high. It's quite low. I should not say low. I think it's as a routine mortality rate. So I just mentioned some points about the first was transmission features. I think the definitely human-to-human transmission, there's no doubt about that. I'm not going to talk too much about that. So the main point is, I think in the States, as well as in the Europe, so people should pay more attention to those with asymptomatic patients. We call that virus carrier. As you know, the transmission roads will be close contacting or droplets here. And then maybe there's no evidence showing mother to child vertically transmission. during delivery. So there's some evidence showing there's a transmission from vehicles. Species, sorry. So respiratory transmission is okay. So that's no doubt about that. So, and also we should think about the possible fecal or urine respiratory transmission here. So as you know, the Princess Diamond Princess cruise ship. So actually, when it's closed, embarked to the harbor, and then that's at that time that's more than 700 patients infected. Actually, eventually this cruise approached I think 1,000 patients infected. So this is one thing which told us. So maybe not only face-to-face talking and infection, maybe have some closed circle of the tube and some sewers and some others. So this is the first paper showing the people with no symptoms, but actually had the virus carrier will be infected. So this gentleman going to that's from Shanghai to Germany and have a business meeting, and 2 persons accompany him. And when they flew back to China, and then developed symptoms, and 3 days later had shown positive PCR test, and following that, 2-person partner developed symptoms as well, and also subsequently they had been confirmed as having COVID-19 infection. That's the first thing. I think up to now, the dynamic, the so-called reproductive, the number varies from countries to countries. But so far, I think based on in Europe and the United States, it really close to 3, the so-called basic reproductive number. So we have never seen any study showing the natural cause of the RO, the basic reproductive number. So it's difficult to say. But anyway, it's much higher infectivity as compared with SARS, coronavirus, and MERS, of course, and seasonal flu influenza. So the very important point I would like to mention is, so this is some data showing that in the early stage of onset, this is in nasal swab, this is a throat swab, and this is combined together. You can see virus loads much higher in the upper airway in the early stage of onset, 3-4 days, and decline after 1 week. In other words, the higher the viral load may be more contagious. So that's my summary of this transmission. So because of the high basic reproduction number and high mortality, so this is at the moment is 3.4% as compared with the influenza, that's 20 times higher or more. And transmission to human by asymptomatic virus carrier, that is very important. I suppose our US colleagues should pay more attention to this one. So in order to avoid more spreading, so faster spreading, and also the earlier the stage of the patient's onset, the higher the infectivity. So in China as well as in Asia, in some other countries, so we will be very aware about the foreigner coming to China. So of course, we really need to keep unobstructed of the sewer and exhausted tube. So diagnosis, just very briefly to mention about that. So of course, we are doing the double check. So either the RNA or the antibody, in particular IgM, and differential diagnosis are also important because some of the patient actually was misdiagnosed as having COVID-19. Actually, he suffered from influenza. So this is some method. I'm not going to talk too much about that. And here's COVID-19. So serum IgM or IgG. Now we use peripheral blood, trying to make a check up to the passengers passing crossing the customs. So here IgM assay, here IgM assay. That's control. IgM here, and that's IgG. So separate. So we can make a double check of PCR as well as antibody. So this is we have developed some differential diagnosis. Not going to talk this, and then we can differentiate the COVID-19 and influenza A, B, or some respiratory syncytial virus as well. So the third point I would like to mention about clinical characteristics. And as you know, we had collected the first 1,099 patients at the very beginning in China. So for the data is collected from 500 hospitals. So more than 500 in 31 provinces. So we use the criteria of American Thoracic Society criteria. And the primary endpoint is composite endpoint, either ICU admission or invasive ventilation, intubation, or death. So what happens in this kind of group of patients? So the incubation period, the average incubation period is 4 days, from 2 to 7 days. Of course, some of them as long as 14 days, about 1%. So in a few very rare person, only one is 24 days. And and also very important, the clinical symptoms, usually fever and cough, and fatigue is the most common. But be very much aware, in our group of patients, about 50% of the patient present with a fever on admission, and then they develop fever. So more than 95% of patients actually have fever. So that's one thing. And the second point is during the X-ray, so CT examination, GGO, and bilateral infiltration is most common. But that also always happens in the early stages, close to the subpleural area here, subpleural area. And also very important point about the laboratory indices. So lymphopenia is very important. And also, of course, CRP elevated and LDH, direct bilirubin. So this is a very apparent characters of this patient laboratory. So actually we have made a prediction of the critical ill patient, which are very difficult to be cured, to be treated. So we had found 10 indices, risk factors. Of course, this is you are quite familiar with the abnormal, the situation, the extent, the abnormal X-ray and abnormality, elderly age, and multisis, and dyspnea, and unconsciousness, and the number of comorbidities. And also the history of cancer, which is very important. And also 3 of the laboratory indices are very important. First, lymphopenia. And the second, LDH, elevated LDH, and also direct bilirubin. These 3 is most important of that. So we have total point, and then have some probability of having, with the prognosis of going to the severe disease and moderate and mild. Of course, the majority is mild. So I'm going to talk a little bit about we have actually have few randomized studies. So and so far some results going up. So like Calitra and chloroquine and IL-6 receptor antibody tocilizumab. So last night we have discussed with our colleagues from Harvard University Medical School. They are also doing some clinical trial looking at the tocilizumab. So to treat the patient with cytokine storm. And then there's Chinese herbs. So we call that the Lianhua capsule. And also this kind of machine, it seems to be very useful. Hydrogen and oxygen mixed gas inhalation, as you know. So 30 years ago, we quite often use helium oxygen mixed gas to reduce the airway resistance of the gas. Convalescence plasma and remdesivir. So what happens this week? So that's a paper published by Dr. Chaobin, and as compared with the other treatment, whatever treatment, including Calitra. So including others like some other kind of kind of treatment. So as compared with the other treatment, so the Calitra didn't show its efficacy in terms of shortening the duration of clinical improvement, as well as the reducing the virus load. So just published. This is one, and the second one is about the chloroquine. So this is chloroquine is first raised from China, and now also the hydroxychloroquine, and also been doing some clinical trial in the United States as well as in China. So this is the two reviews, but they have not doing any clinical trial at that time. So we had done some research work looking at the chloroquine from in vitro as well as in clinical trial. And this is, we have found the target protein here. So 3CL, so protein is a target for the chloroquine. And also we have been using the dose with 5 milligrams twice a day for 10 days. And then actually we have measured the plasma concentration so far so up to 1.5 micromoles, which is far more less than toxic level. So we have found a paper from the New England Journal of Medicine in the year 1988. So that's rescued some patients with using chloroquine to commit suicide. So that blood concentrations as high as 17 or 25. So in other words, it's quite safe and also very close to the concentration of EC50. So that's why we use that. So this is the result had submitted to the journal, and I just should very briefly show the result of this. So in a patient with close to 200 patients use this dose. So I just tell you the result because they are going to publish that. So patients in the chloroquine group have a shortened time to reach undetectable viral DNA as compared with the control group. 3 days turned to negative as compared with 9 days. It's pretty good. And the second is by day 10 and day 14. A high proportion of patients had the viral RNA turning to negative in the chloroquine group. This is the percentage as compared with the control group. It is also significant. And also the duration of fever significantly shorter. That's 1 day as compared 1 to 4 days in control. So this is the result. So in other words, we found chloroquine seems to be effective in the management of COVID-19 infection. So the second data is coming out now, is summarized as a paper to submit to the journal. So a lot of them have done some in vitro study, and this is one is called, we just call the 莲花清瘟胶囊, is called LHQW. So, and it really, so although the antivirus efficacy is not that high, as high as chloroquine or remdesivir, so it's not, the SI is not that high, so not that low, not that high, sorry. And then we have done some in vitro study showing that really have some antivirus activity. So by using 莲花清瘟胶囊. And I just tell you the result. We have submitted this paper. So we are doing patient, making a national study in 284 patients, and with the treatment to control one versus one. And the result, we have found high overall recovery rate in treatment group as compared with control. Here is the result. And faster symptom recovery of the treatment group, 7 versus 10 days, and high rate of improvement, the chest CT manifestations also show significant improvement, and so on. However, we didn't find any significant difference in converting rate. So the patient turning to severe cases, no difference between two groups. Seems to be a little bit better, the tendency in the LHQW group. And as well as the virus conversion time. So 11 days versus 12 days, no significant difference. Anyway, that's shorten the symptoms and improve the recovery, and this kind of Chinese traditional herbs. So the second point I mentioned about convalescent plasma. So we have a data just coming out as compared with the control. But first we have done 10 patients. So as an open trial, this is just published. Maybe it will be published soon. So in the preprint paper, the recovered donors with the neutralization antibody titers about 1 to 640, and 10 patients who just received 1 dose, 200 ml of convalescent plasma. A primary endpoint is safety of the convalescent plasma transfusion. A second endpoint, improvement clinical symptoms, laboratory parameter within 3 days after the infusion. This is the primary result. So in terms of CRP, the lymphocyte and aniline aminotransferase and aspirate aminotransferase, and also improvement. And total bilirubin doesn't show too much change. And oxygen saturation also improved. And very important point is the antibody. So you can see the serum, the virus load is going down here. Serum neutralization antibodies. This is before. This is after. You can see the antibody titers is much higher. The majority of them is higher as compared with the before. And then serum, the RNA load is going down. So all of them showing negative as compared with the quite positive before infusion. So this is the result before, after, before, after. So this data had published in the preprint, and then will be published soon. So the last is the last management is a special issues of mechanical ventilation. I suppose this topic will be talked more by Dr. Luo in Wuhan. So I just mentioned some questions about that. So in some of the situations, which is quite different from the so-called routine IARDS, or from the appearance of SARS 17 years ago. So patients present with exhaustional dyspnea with normal respiratory rate under HFNC or non-invasive ventilation. So at this time, always leading to a delay of intubation, which is not good, which has caused poor prognosis. This is one situation. Another one is, although the PF ratio improved soon after intubation, but we have found some difficulty in withdrawing the sedative or muscle relaxant, owing to the unsynchronization between patient and ventilator, the rhythm, the breathing, so which is quite different from that. So from the autopsy, so in addition to the small vascular necrosis, fibrosis, interstitial fibrosis, and some others, so thickening of the small airways and so on. So we have found necrosing alveolitis, in particular, some very sticky mucus falling in the alveoli as well as the alveolitis. Bronchiolitis. If you look at that, so seems like that. So so-called fibrinousness, exudative. This is G here. So I'm not going to talk too much about that. So you can see when we shut out the mucus in some of the patients, the secretion is really viscous, sticky, so which will cause the difficulty in unsynchronization of putting in ventilator. So to improve the efficacy of mechanical ventilation, early cleaning of viscous mucus in a small way remain to be solved. So this is one we have not done too much about that. Probably this is one clue should tell our U.S. colleagues. So whether the high dose of N-acetylcysteine, lavage, or intac will improve the situation. Whether, and also Professor Bali told me, whether we can use the Parmesan DNAs, so which is used to treat the patient with cystic fibrosis, will be useful to solve the sticky mucus, remain to be solved. So now we have been doing hydrogen and oxygen mixed gas to reduce airway resistance, just like 30 years ago. So use helium and oxygen mixed, and of course hydrogen is much the density much lower than helium, will be much better. On the one hand side, to reduce the gas to reduce airway resistance, and the other hand, to hydrogen have the capable of antioxidant. So that's very clear, very simple machine to have electrolysis to change the water into oxygen and hydrogen. So by using this method, the patient dyspnea, the symptom of dyspnea, really can relieve in the second or third days, which the result will be coming out very soon in these few days. So finally, I would like to mention about the China's strategy in controlling further spreading. Since the expert group had announced on the day of January 20th, so we announced there's definitely human-to-human transmission, and are also confirmed medical staff have been infected. So at this moment, two choices will be decided by the government. So as you know, probably know, one is suppression, another mitigation. Suppression, they take a stronger action, and that will make a great impact on the economy. So that's the advantage, just reduce the number to minimum, but of course will cause a great impact on the economy. Mitigation, of course, that's helpful, but it's owing to its very high reproductive number, whether the so-called delay strategy will be effective or not. So actually in China, we choose the first. Lockdown Wuhan in 23rd. Don't go to Wuhan, don't leave Wuhan, and make it more transparent. Real-time announcement of number of diagnosed suspected patients every day in each city nationwide. And also very important procedure is taken the so-called interagency mechanism. What does it mean of interagency mechanism? That's down to the community level. That's so-called everybody should have an early protection. So wear mask, avoid going to the people who the meeting and crowded room, and early detection and early diagnosis, and actually the power is laid down to the big hospital to determine this patient, whether the patient can be diagnosed as having COVID infection, and of course early isolation. And in 1 week later, and then we have a compulsory checkup of all close contacts, not only for asymptomatic patients. So this is some action taken in Wuhan at that time. So you can see here the whole process, the increasing number of patients. You can see from the 23rd to just 2 weeks to the 3rd of February, just 2 weeks time. So the number in reaching the peak, just 2 weeks, and another 2 weeks is going down to under the basic control. That all together just took one month. So the problem is we have make a comparison. You can see here is in China, 2 weeks time reaching the peak, and 2 weeks time going back. And this is something happens because some suspected patient, we can make sure whether it is really infected with COVID-19 or some others, and make sure, and then going up. And now in the world, so the majority of the country had the launch and the lockdown or some other restriction action, national government action seems the year at the beginning of March. So 3 days or 3 weeks is over. Now seems to be in Germany, in Italy, and of course France, and some Iran, perhaps some another Asian country is going down at the moment. However, in Spain, in particular in the United States, still going up. I've heard about that newly patients much higher this morning. So in the state, so we have make a prediction of the real world situation within with this additional parameters. I'm not going to talk too much about that. In particular, the government interference. So the curve is we use the AI to make sure to validate whether it is true. This curve actually now is the curve. The maximum is close to 80,000, so more or less the same. So if we can announce this policy 5 days earlier, so now the curve maybe like this. If late 5 days later will be like that. So in China we have 170,000 patients. So that's the point of me. So I suppose the government should take a stronger. I'm thinking so the future is good. So if all the government in all, of the different countries take a very strong action of that, so the peak will be reaching, and then the total number of patients, the new diagnosed patient will be going down greatly. Thank you very much.
Thank you very much, Professor Zhong, for the excellent lecture and your point and opinions and suggestions. And hopefully by taking the social distancing and lockdown, the number in Spain and US can be decreased in next 2 weeks or 3. And our next speaker is Professor Gerard Kriner. Professor Kriner is a chair professor of thoracic medicine and surgery, Louis Carr School of Medicine at Temple University. And today he's going to talk about strategy of US status and Temple University experience in dealing with COVID-19. Professor Kriner, please.
Thank you very much. And it's a pleasure to be involved with my esteemed Chinese colleagues. It's hard to follow Dr. Zhong, who is one of the world leaders in SARS as well as COVID-19, and also Dr. Li, Lu, Tam, Wong, and Lam, as well as my American colleagues, Dr. Rothenberg and Dr. Hogarth. So I'm going to give the perspective of someone from the United States that's starting to face this epidemic now, and give some examples, I think, which are instructive to the rest of my US colleagues, and really emphasizes the need to learn from our other colleagues from throughout the world in how to handle a pandemic such as COVID-19. So I did this morning at about 7 o'clock, looking at what it looked like in the United States. And as you can see, the United States ranked 3rd at that time behind Italy and China in terms of the number of patients that were infected with COVID-19, with New York and the New York surrounding area being about half of what the United States infection was at that time. New York itself, New York City, is about 20,000, but the surrounding suburbs were about 15,000 more. And as you can see, Philadelphia was about 342 patients. But as you can look throughout the United States, you can see the eastern seaboard is as dense with COVID-19 as it is throughout some parts of Western Europe, including Italy and Spain, as well as the eastern part of China overall. This was at 7 o'clock this morning. But by 3 p.m. this evening, here in, we're about 12 hours behind what it is in China right now, we have 83,000 patients that are infected with COVID-19. The United States has more infected cases than any other place in the world, which I think it amplifies. We failed to learn the lessons of social dispersion and distancing that was emphasized by our Asian colleagues. And you can see the steep upward slope of this curve, which is driven by some of the Western European countries and the United States. This is from the New York Times this morning, which gives a more current snapshot of the impact of the epidemic in the United States at this time. You can see, first of all, that all 50 United States are now involved and have reported COVID-19 cases. But the concentration in the United States now, which first started in Seattle, Washington, is now centered in the northeastern part of the United States, with New York and northern New Jersey being the epicenter. And where I live now in Philadelphia, we're right on the verge of being on one of the inner rings of the spread of this illness overall. This is one of the important things that Dr. Zhong emphasized, that if you look at the impact of the transmission of the disease and the rate of infection of new corona cases, you can see that over the last 7 days in the United States, the case rate has been increasing by about 30% each day. You can see that this hasn't crested on March 25th, mainly because we decreased the amount of sampling that we've done because of the protection of protected personal equipment because of the shortage of that right now. So this would be even much higher. And what we're seeing now would still see a steep slope and increase in the number of cases that we would expect over the next 3 to 4 weeks. This looks at the worldwide rates of new cases and deaths. And as you can see here, when it becomes darker, those are higher case rates overall. You can see in mainland China that there was, before they realized what the cause of this was, that they had increasing cases that occurred, and then they had lockdown of populations in Wuhan base itself, identification of where the epidemic came, and you can see over a period of time a decrease in the rate of cases till it's back down to almost where it was before it started in December or November of the year before. You can see that in Italy, however, they had a very short period of time with increasing cases, and then there was an acceleration of cases overall. Same thing happened in Spain. And unfortunately, in the United States, it looks like we're behind Italy and Spain, but the same trajectory of a shorter period of lower number of rate cases, and then an escalation of higher case rate that happens much more dramatically in a steep slope upward. That compares to what you see in South Korea, where you can see that there was never a higher case rate that we saw in Italy and the United States, with greater measures of social distancing that was enacted and a greater emphasis on lockdown and prevention of transmission from one person to the other. The important things that go with this case clustering, however, is population density and whether a city is a travel hub. You can see in Philadelphia itself, we can look at these areas in Philadelphia and the surrounding high density areas. You have a much higher case rate. And this is seen in the eastern part of the state. In the other major city in Pennsylvania around Pittsburgh, you can see a clustering of cases. And in other places throughout the state of Pennsylvania, you can see a much lower density of case rate because they're not really density populated and they're not really travel hubs overall. And if we look at throughout the United States, the major factors that go in how the virus was contracted are really three. It's whether patients had travel outside and within the United States, whether they were residing in a nursing home or a skilled nursing facility where the patients are immobile. Well, one infected patient who might be a caregiver or a visitor goes from patient to patient, and it spreads rapidly throughout those immobilized and more infirm patient populations with a higher degree and more severe number of comorbid conditions. Or if you're in a cruise ship, which is in essence a floating hotel that travels throughout with a captured patient population overall. What we haven't realized too much in the United States, like was realized in China and some other countries, is travel within large countries like the United States. It's more important to cause social distancing as well as lock down the populations, especially around high concentrations of centers of cities where there's a greater density of infection. Now, it's been reported that most of the fatal cases were over the age of 70, including some in the 90s. But in essence, patients who are younger age who don't have more comorbid conditions because of the propensity of this to have respiratory tropism can occur and cause greater compromise. This is a patient that I saw today who was a 45-year-old male who had no comorbid conditions, was seen as an outside hospital in an emergency room a week ago for cough and some mild shortness of breath and sent home. And a patient presented about a week later to us in ARDS in respiratory failure and needed to be intubated and prone. Patient that presented a much more severe form thrust disease. So what are the lessons that I've learned in Temple and Philadelphia? First of all, listen to your colleagues in China, Italy, Spain, and New York City. There's nothing different from our patient population than what occurred in these other centers. And they have learned over the last 3 to 4 months the things that are important to prevent and treat this disease. Be prepared for a high surge of sick patients with high respiratory demand. We haven't experienced really what was seen in SARS in the United States, like Kyle said before we started the conference a couple minutes ago. But this is a unique phenomenon where we see a high surge of sick patients who require high levels of respiratory support, which we haven't seen in the US before, at least in my career over the last 35 years. You need to have policies and procedures in place, not only to diagnose, but to treat and prevent the spread in the population that you serve, but also in your facility and your staff. You have to be careful to protect your treating staff because you will lose them to treat other patients, but they also might be a vehicle to spread the infection to the patients that they're trying to treat. and they don't even know that. First and finally, or one of the other important points, COVID-19 needs to be the primary concern for any medical center that exists in a cluster zone. You need to have a separate hospital. You need to have separate ICU beds. You have to have a separate CAT scanner. You have to have a separate elevator to transport the patients from where they come into the institution. You need to have a fever clinic separated from the regular emergency room so you can diagnose these patients and not contaminate your other patient population who hasn't otherwise been infected. As Dr. Zong mentioned, respiratory equipment is different than what we usually have. The priority is for intubation and positive pressure ventilation in terms of effectiveness over high flow nasal therapy versus BiPAP itself. And you need to be particular for the protective gear that your staff wears, and also to kind of garner the protective gear because we don't have as much going around. I learned from one of my colleagues who was fortunate and is my friend, Jinglong Chen, who's now working at Wuhan University, who is very open and proactive with us months ago in determining what we needed to do at our facility when this epidemic hits, not if this epidemic hits overall. Also, you need to organize multidisciplinary teams of providers. This easily overswamps the amount of critical and pulmonary care physicians that we have. Received a note today from one of our colleagues in NYU Presbyterian, where they had 1,000 COVID positive patients admitted to their hospital and 260 patients were intubated. They had a dearth of intensivists to be able to treat these patients, and we're looking for intensivists from other parts of the country to come and help them. So other people can be parts of your team. Anesthesia, hospitalists, even endocrinologists can come into play where you can help patients be treated in the emergency room, the outpatient, or even in your rounding wards. And you need to have a high throughput and turnaround COVID-19 testing. As Dr. Zong mentioned, which we don't have in the United States, having a test that can turn around within 45 minutes or an hour is instrumental in detecting patients who are COVID positive from those who are COVID negative or convalescing from the disease. So your hospital isn't occupied with a lot of patients with unknown status who are waiting the test results. In some parts, we've been waiting up to 5 work days for the test to come back. One of the important benefits, I think, of this epidemic, and you always have to look a little bit of the golden lining in this, is the value of telemedicine. The use of telecommunication has been widely used in business world, in other parts of what we see, but not so much in medicine to date. And using things which we have now been forced to use with prime and remote care teams, where we can use Zoom like we're using tonight, or WebEx or other modes, where we have support teams that can help look at the data, the radiographs overall, help to write the notes, help to write the orders, help to put patients in to research protocols overall, can support the primary teams and offload them. And finally, we use this program that was developed at Temple using a telemedicine program where we monitor patients on a daily basis to look if they're sent home. We look at their symptoms on a daily basis to make sure they're not escalating. And we also look at our healthcare workforce to make sure they're not developing symptoms that would be concerning for development of COVID infection overall before they report to work each day, to make sure we have a healthy workforce to come in. So I think the final lessons are, I thank my colleagues overall who have instructed me how to take care of these patients. And I also thank Broncus Medical for putting this conference together, because learning from others who have faced this in the world, who are skilled in how to diagnose, treat, and prevent, will only help us take care of our patients better. Thank you very much.
Thank you, Dr. Kreiner. It's very good lecture, and thank you for your insight. And I do hope after this disaster, the medical world will learn a lot from this, and we shall improve further in the future. And our next speaker is Professor Li Xiyue. Professor Li is the Deputy Director of Guangzhou Institute of Respiratory Health, and he is also an excellent bronchoscopist. Today, he's going to talk about a brave topic, how to do bronchoscopy in COVID-19 patients in view of this highly contagious disease. Professor Li, please.
Okay, thank you, Dr. Lim. And Dr. Zhong have give us the whole picture of the COVID-19. I'm going to focus on the bronchoscopy in patients with COVID-19. I would like to talk in these 5 aspects. First, I'm talking about the general procedure for bronchoscopy in patients with COVID-19. After the outbreak of the COVID-19, the Chinese society have produced export concerns in early February, just about 10 days after the outbreak of the COVID-19 in China. So for these concerns, for the bronchoscopy, there are these main points. First, conducting bronchoscopy on patients with COVID-19 is a high-risk procedure in which healthcare cares are directly exposed to the virus. And the second point is that the indications for bronchoscopy for other diseases should be strictly mastered. And bronchoscopy should not be used as the routine means for diagnosis of COVID-19 infection sampling. And the personal protective equipment (PPE) is required during the bronchoscopy. So here's the PPE, the hood with the high air pressure. Here's the picture showing the doctors doing the bronchoscopy in my hospital. And as we know, the incubation is the helpful tool for the treatment of the severe COVID-19. So the incubation with the bronchoscopy guided is the useful tool. We analyzed in my hospital for with the 20 case. These all 20 patients were successfully incubated under the guidance of the bronchoscopy, and the health workers were protected under the personal protective equipment (PPE) with the positive pressure protective hood. For these procedures, the time is about 2 to 3 minutes, and for these 12 cases, there was no complications. And after the procedures, 9 health workers who involved in the procedure, there are no infected after detect for 2 weeks. For the diagnosis of the bronchoscopy in patients with COVID-19, here's the patient we can see that the mucus with the hypolemia and swelling mucus, and there are a small amount of the secretion. So this is for these patients, for this case. And more common is is like this one. This one is shows the bronchoscopy shows the smooth bronchial mucosa and clear lumen, and the little secretion is more common for the bronchoscopy in the COVID-19. Just that there are no much secretion in the neck or airway. You see the diagnosis for the different sample. This study was finished in Shenzhen, China. This is preprint. It had not been published. This study shows us that the different sample of the diagnosis year for the viral RNA. From the after the day after onset, 0 to 7. So you can see here in the early stage, the sputum is is the highest sample compared to the throat swab or nasal swab. But at the 8 to 14 days after the onset, here we can see the buffer. We can see is the highest year for the diagnosis compared to the sputum or nasal or throat swab. Also, after 15 days, the numbers it's still the BAF still the highest year for compared to the other samples. I would like to show the case we have did in my hospital. This is the male 49 years patient. At the 2 weeks after onset, the patient was very critical. So we incubated and the patient received the mechanical ventilation. But during the mechanical ventilation, the airway resistance very high, and the patient showed the hypercapnia. Dr. Zhong checked these patients and then asked, seems there's the high airway resistance. So Dr. Zhong asked us to check the small airway. So we used the OCT, optical coherence tomography. This is the machine, and here's the we are did at the time. There are different index for measure the airway with the OCT, like the lumen area, and also the airway wear percentage. So here we can see the different picture. This cluster. This see the seems time this see the longitudinal section. We can see for this case at the RB8 compared to the normal subject. Here we can see the airway thickness is similar to the normal subject. Also for the lumen diameter, this case is similar to the normal subject. But we can see for this case, there are some sputum inside the lumen. This is the lumen area and the airway wall. The patient compared to the normal subjects. So for the bronchoscopy with the OCT for this case, we can find that there was no significant decrease in the lumen area of the bronchi of the grade 3 to 9, and the bronchus wall of the grade 3 to 9 is similar to the lumen area, but we can see the mucus retention occurs at the most of bronchi of the grade 4 to 6. And in terms of the treatment with the bronchoscopy, we can clear away the airway secretion and also the BAF. Here's the reported before bronchoscopy. Here we can see the left line like this, and 2 hours after the bronchoscopy, eliminated the secretion in the left bronchi, and we can see 2 hours after the 2 hours here, the left lane is much clearer than before. And this case was treated by my colleague, Dr. San Nin. Now he's still working in Wuhan. For this case, before he did the bath for this case. Before the bath, here we can see some the line is not clear, but 4 days with the 3 times of the bath. Here we can see the buffer. There are some very sticky sputum inside, and the line is much better, much clearer than before. And in another case, we can see with the bronchoscopy. Here's the main bronchus. Not much secretion inside. This is the big and middle size of the airway. And then when we get into the further or small airway, we can see the secretion and also some infection size for the mucus. And here we can see some very sticky sputum inside the bronchi, the small airway. And I would like to talking about the bronchoscope we have used. Usually there were typical video bronchoscopy, but for the COVID-19 we did the bronchoscopy on site. So for this is the portable video flexible bronchoscopy, and there are another single-use flexible video bronchoscope like this. It's very convenient. Use this bronchoscope beside the on-site procedure. So finally, I would like to have the summary. Bronchoscopy on patients with COVID-19 is a high-risk procedure. So the personal protective equipment is required during the procedure. In some cases, bronchoscopy has a unique advantage. Thank you very much.
Thank you, Professor Lee, for telling us how to do a bronchoscopy safely, and what are the cardinal features of these patients' endobronchial view. And our next speaker is Professor Luo Fengming. Professor Luo is the Deputy Director of the Department of Respiratory and Critical Care Medicine in the West China Hospital. And actually, he led a team of medical staff volunteered to work in Wuhan for 2 months during the Wuhan epidemic. And in today's lecture, Dr. Luo is going to talk about how to diagnose COVID-19 and how to have good personal protection for healthcare workers. Dr. Luo, please.
Okay. Hello, everyone. I want to share my experience with in Wuhan, and so I come from West China Hospital in Sichuan University. I want to talk about diagnosis and personal protection. First of all, diagnosis, and we all know about that this virus very well. Here's the cases of in USA, just mentioned by other people. And New York is the first one. And I also concerned about the Ohio because I stayed in Cincinnati for 1 year. And also Ohio is different from New York City because there's a low, so many, the population is less than New York, so it's different. So we concerned about it. To the pathology, it's the inflammation and mucus we should pay attention to because we should treat the inflammation. Also, sometimes we should treat the mucus in the lung. And as to the history of epidemiology, as mentioned by Professor Zhong, it's 1 to 14 days, and also some family members, colleagues, and friends have the same symptoms, and so it's clustering disease. And the fever and dry cough and fatigue is very, very common. And from my experience, lost congestion, running nose, and the sort of the throat is not so common. Sometimes the patient has diarrhea. This diarrhea may be due to the infection of the virus. Sometimes maybe just due to the medicine. For example, Abidor can cause diarrhea. In severe cases, dyspnea is very common after the 1 week of the onset of this disease. And in some cases, they can rapidly progress into IRDS, and we should pay attention to it. Some children are relieved very quickly, and the middle patients only showed a low fever, and the symptoms not so obvious. We also use the electronic stethoscope device to listen to the lung. Doctors maybe said that why you use the electronic stethoscope, because we put on the protection shoes, we cannot use the regular stethoscope. We can see here that there's a wheels and also cracks. Also, we can find the micro cracks just in the basal of the lung, and most of them located in the base of the lung. And as to the laboratory test, the blood routine examinations said that the neutrophil is almost normal, and sometimes decreased of the lymphocyte. And the CRP and the D-dimer may be increased, and as the lymphocytes decrease progressively as to when the disease progressed. And we can take the various the specimen, we can collect the specimen for samples from throat swab, nasopharyngeal swab, and also anal swab. And the sputum has the higher positivization than other. And we should test the samples within 4 hours. If you cannot test the samples within 4 hours, you should preserve it in the 4 degrees. And if you want to test it in the later time, you should preserve it in the lower condition. And we use the RT-PCR and also NGS to test the virus. And we also have some experience about the test. We use the nasal swabs and also pharyngeal swab, collect the sample at the same time. You can see here we have 100 patients, and we collect the samples at the same time. We can see here that the nasal swabs has higher positive ratio than the pharyngeal swabs. It's only 50%. When you use the pharyngeal swab, you have to face-to-face to the patient, so the patient breathes out the air just direct to you. But if you use the nasal swab, you can stand just beside your patient, so I think it's safer than pharyngeal swab. As to the IgM and IgG, Professor Zhong talk about this. And as to the CT scan, there's a small patch in the early stage, and then developed into the GGO, and after that maybe consolidation, and then when the patient get better, maybe the GGO appeared again, and the subpleural line is very obvious. And as to the diagnosis, we should ask the history of the patient and also clinical symptoms. We should exclude other various pneumonia and other pathogens. When the suspected cases confirmed with the virus detection or some IgM, IgG positive, we can make a confirmation diagnosis. Someone may be asked which one is the better one, CT or nucleic acid. At first, nucleic acid is took a longer time, just as someone mentioned before. It's maybe 4 or 3 days in Wuhan, but improved later. And in patients, if the patient is not diagnosed in time, then the patient cannot be separated and classified in time. After the inpatient is better, beds are occupied due to not able to examine in time, because if we should test 2 times for elective before the patient can be discharged from hospital. And in the late period, nucleic acid testing for selective problems, maybe due to the specimen collection and preservation, and also transportation and some processing and detection technology and the reagent also equipment can affect the result of the test. So as CT has high sensibility but lower specificity. So we should use clinical and laboratory tests and image put together to make diagnosis. If you don't have timely testing for virus, I think clinical and image is very important. You can also make a diagnosis and treat the patient and isolate the patient at the same time. To the classification, we classification the patient into middle, common, and severe, and very critical condition. And maybe some patient can progress in very severe condition. For example, the lymphocytes decrease very quickly, and also IL-6 CRP increase significantly. Also, lactic acid progressively increased. If the CT lesions progress very rapidly in a short time, for example, within 3 or 5 days, it's maybe worse. The patient condition may be worse. Some factors can predict the patient maybe progress in the critical condition. For example, age. If the patient older than 65, the obesity, the overweight. If the patient BMI greater than 28. Also, the patient had chronic disease such as COPD, IPF, CTD, ALD, chronic heavy smoking, also hypertension, also some nervous system disease, and also CKD. This kind of patient, maybe you should pay attention to them, and maybe progress in critical condition. Differentiation diagnosis, we should exclude some other pathogens, especially the influenza virus. We should pay attention to them. Also, we should exclude the other disease. For example, the organizing pneumonia, Sometimes maybe secondary organized pneumonia is can be found in the COVID-19 patient. So novel coronavirus is still challenging for us in the clinical practice. For example, sometimes clinical symptoms apparent, but nucleic acid is the negative. Some CT changes the obvious nucleic acid is still negative. Sometimes the patient does not have a clinical symptom, but the nucleic acid is positive. Sometimes clinical symptoms disappeared, CT lesions completely resolved, nucleic acid is still positive. I want to share some cases with you. This one is a female, 42 years old, and she was admitted to a hospital for fever and cough for more than 10 days. X-ray is normal, so X-ray is not work in the COVID-19. In January 6, the CT scan can see here the small pitches, small some lesions and sometimes some consolidation. Most of them located under pleural, and the patient has fever and dyspnea. 4 days later, the ground GGO appeared in the CT, and the patient has the dyspnea and fever progressed and peaked. 10 days later, the patient felt better, and the ground gas opacity improved. And we can see here reverse halo sign here and here. They indicate that the patient improved. I also want to share one the other patient, the 37 years old man. He is a doctor in the Red Cross hospital in Wuhan. Fever for 4 days. You can see here it's almost normal here, and maybe 5 days later, there's a lesion in middle lobe, right middle lobe here, and after treatment disappeared. All the lesions almost disappeared in almost 2 weeks. And you can see here the consolidation here, and the GGO here, and after treatment resolved. It's almost the same. The blood test is almost normal, just the lymphocytes decreased in February 25th. And the liver function injured just because, I think it's maybe just because of the medicine we used. We stopped some medicine and improved. And the antigen for respiratory tract pathogens, the influenza A and B is negative, and other. We also have blood culture, it's negative. We can see here its temperature is very high, and we test the nucleic acid. All of them, and from different sides of the body, it's all negative. IgM from very weak, positive to positive, but the IgG is still negative before discharge from the hospital. We stopped all the antibiotic and treat just with the injection of the interferon. And after that, the fever resolved and the patient discharged from the hospital. And also this is of 22 years old female, fever for 2 days. And we can see here GGO in the February 1st, and the positive of the nucleic acid, and after that the lesion improved and resolved. after the treatment, but still the nucleic acid is still positive for a longer time. It's very common in patients with diabetes, the nucleic acids remain positive for a longer time. For example, maybe 1 month or 40 days. As to personal protection, because the virus can transmission from droplets and also contact and aerosol. So we use the personal protective equipment for respiratory protection and also face shield and also protect the shoes and gloves. And sometimes we use the boots. It's a standard protection and enhanced protection and also additional protection. If you perform bronchoscopy, just like this one, we perform bronchoscopy, the positive pressure head cover should be applied. When you perform the sputum aspiration, also the sampling of bronchoscopy, intubation, and this kind of procedures. When we should put on caps first and then test the put on the mask N95 masks, and you should test the mask and also put on the check the protective clothing and put on them, and wearing gloves and wear outer protective clothing and also outer gloves, and put on the face shield and sometimes the shield, the boots, and check them check again. And it's what I like the look like in when I working in the ward and consulting the patients. And when you talk of the protect shoes, you should remove the face shield first and take off outer clothes and then inner clothes, and also the masks and then the cap. Never touch yourself before washing your hands. It's very important. Hand hygiene is very important because the virus can transmission from the contact. So wash your hand with running water is very important. So only protect yourself, and then you can help more people. We have 42 staffs, nurses and doctors from other provinces to Wuhan, to Hebei province. As a report from the government, no one tested positive for the COVID-19 in these nurses and doctors. In January 25th, we have 20 nurses and doctors from Chengdu, and almost 2 months later, we returned from Wuhan to Chengdu, and we test the nucleic acid. All of us have the negative test. So it's very important to protect yourself with the proper personal protective equipment. That's all what I want to say. Thank you.
Thank you, Professor Luo, and thank you all the speakers for excellent timekeeping. Now then, we are going to have this discussion part, and all of you are welcome to raise questions and comment, etc. That's all of us are clinicians. We face a lot of COVID-19 patients now or in the future. I guess a lot of questions will be regarding the treatment. May I take the first question to Professor Zhong? In your chloroquine study, it has been shown that the treatment arm has faster decrease in viral load and shorter duration fever. what about the clinical outcome? What about the conversion rate to severe disease or intubation or mortality? Is there any difference in the study arm, control arm?
Okay, thank you very much, Dr. Lam. So I think the result will be coming up soon. So because we just have a very quick summary about the efficacy of the virus turning into negative. That's extremely important for us because so far we have found no any medication available for turning negative earlier. So that's why we give the first step of a report, and then we're following on this. Thank you.
And there are studies showing that angiotensin converting enzyme has been the entry port for the virus. And now people are talking about, shall we stop ACI or ARB because this can upregulate ACE2? What is the view of your view regarding this point? Shall we stop ARB or ACI in hypertension patients?
Yeah, I think this is theoretically say that's correct, and then we have been noticed this problem as early as the outbreak of SARS. So people had just take some ABR, so inhibitor, so ARB inhibitor. So and then in those with hypertension, and in those who have not septic shock. So that's one way. Now we are on the way to use another pathway to supply ACE2 recombinant. So that's another way, trying to protect the lung and improve the lung function. So this is on the way. But I think in the other way, so a lot of people had recommend this kind of a treatment. So ARB and some others from a primary clinical experience showing the benefit, so no too apparent, not that apparent. So that's what I've seen from my experience.
Okay.
Could I ask the question?
Professor Lin, I have a comment about the ARB and the ICEI. We have data about the ICEI and the ARB compared with the CCB, but right now I still summarize the data. I will share the data with all of us later. Okay.
Thank you.
The question that I had is how much is it possible that the use of the ACE inhibitor or the ARB is increasing the likelihood of progression from a mild form of the disease to a more severe form of the disease because it increases the expression of the target ACE2 gene expression in the lung. On most normal individuals, ACE2 expression is actually quite low in most cells of the lung. But I think that in the microvasculature, there's the chance to elevate ACE2 expression for somebody who's on the ACE inhibitor or the angiotensin receptor blocker. That's my question. So if people at high risk are on those drugs, should we proactively try and get them off those drugs and onto a different antihypertensive?
So you're talking about the excuse me. So what's your target organ or so? So excuse me.
Yes. So I'm worried that people who are taking ACE inhibitors or ARBs are at elevated risk of the more severe form of the disease because that leads to the higher ACE2 expression in the lung. Is there any evidence for that?
No, I don't think so. There's no study showing the relationship in between this. So probably I need to find it out. So thank you.
Thank you very much.
Right.
And I have questions by people through the internet. They are talking about when you are facing a patient with severe COVID-19 needs ventilator support. What medication shall we provide? Shall we just empirically give chloroquine, hydroxychloroquine, reproductive, or even IL-6 antibody or steroid trying to stop the cytokine storm. So when you face a severe patient, what will be your choice of medications? Excuse me.
I suppose we actually at the moment we have only a few patients with severe cases, and then quite a lot of percentage of the patient is actually in the end stage. So multi-organ failure or some others putting on the ECMO or something like that. But as far as your question is concerned, I suppose prophylactic management will be very important. So that's what in my mind. So perhaps this person will take a more mucolytic, something like N-acetylcysteine. So with a relative high dose, say like 0.6, 3 times a day, to give some mucolytic. But only for this action is only for mucolytic, or also have some antioxidant characters of this kind of thiol group compound. This is one, and the second one may be using in advance like Parmesan, so DNAs, something like that. So so stop using that. Not use that until the symptoms appear. So the really dyspnea, so really exertional dyspnea. In this situation, so during the biopsy, we can see huge, so sticky mucus stuck in the alveolar, bronchiola. So I suppose this is one way. So now we have using another way for inhalation. So not a high flow nasal cannula, HFNC, but we use hydrogen oxygen mixed inhalation. It shows really effective. We're going to get the result. So dyspnea improves. So something like the second or third days, so that the patient feel much comfortable about that. So that's reasonable because the density of the mixed gas much lower than the hydrogen and nitrogen mixed. So usually, as you know, 30 or 40 and even 50% of oxygen. The other part of the element is nitrogen. The density of the nitrogen and the molecular weight is much higher than hydrogen. So making the airflow is difficult to pass the airway. So reduce the airway resistance. That's a good way. So we use this kind to prevent from those patients to getting deterioration, to get to the severe or critical ill situation.
As to the patient with intubation, you can collect the samples for test the virus. If there's still virus over there, we should also use some antivirus medicine for them. And almost the same as the patient without intubation. We have some experience if the patient in very critical condition, it's difficult to perform bronchoscopy because the oxygen decreased significantly during the procedure. But if you use the ECMO, you can perform the bronchoscopy to perform lavage and wash out the mucus from the far away the small airway. It's we have one case for this kind of patient. Maybe you can try in very critical patient with the ECMO.
Yeah, I would like to add something. During the bronchoscopy for the patient with the ventilation, I think the ventilation mode should be the volume control, not pressure control, and the peak should not be decrease. I think like prefer to keep the same peak before the during the bronchoscopy. Thanks.
Yes, I agree with Professor Li. When we performed the first case of the bronchoscopy in Wuhan, we decreased the PEEP to 5. The oxygen decreased significantly, so we remind the PEEP in 15, and then we can perform the bronchoscopy. Yeah.
Can I ask? I'm confused as to why bronchoscopy was even occurring, given that from a diagnostic perspective, it adds very little, and there's a high risk to then making the provider ill, thereby keeping that provider from being able to treat hundreds of other patients. It seems like an unnecessary risk to do bronchoscopy for the sake of one patient when the diagnostic tests could be done without bronchoscopy. And so I'm curious as to what was the thing that changed that required a bronchoscopy for these individuals.
Yeah, Kai. So I suppose I agree with your point. So it's not too much indication for performing bronchoscopy in terms of making the diagnosis as some others. So I think that's for rescue. So because in China, so we try to rescue all the patients as many as possible. That's a different kind of policy about that. So yeah, you know. So I agree with that. That would get him high risk for a person who perform bronchoscopy. But fortunately, so far we didn't find any patient, any physician, so get infected during bronchoscopy. But actually, it pay a high, expense, very high expense for that. So, but at the very beginning, that's as Dr. Law had mentioned, we perform this in few patients. If we have found the patient mucus staining in a relatively mid and large, so airway, so we perform that. But if the mucus is filling in the alveolar or bronchiolar, it seems to be to us a little bit difficult to wash it out. You're right, the point.
Well, just to follow up, the one scan, the one X-ray that was shown was quite impressive. That you changed the appearance of the X-ray post lavage, but do you have any objective data that you changed the outcome? So, because making an X-ray look better, but having the patient still ultimately die of respiratory complications, again, exposes a limited amount of staff and a limited amount of resources for the sake of one patient.
Okay, can you answer this question, Dr. Law?
Yeah, I think this case is in Wuhan, but not performed by myself. The other hospital. I think it's just because there's a block of the airway with something just like mucus and other things. So the doctor used the bronchoscopy to get out the things, and then the expansion
like
of
a large mucus plug.
Yeah. I think so. Yeah, because in a very short time, the change. Yeah.
Okay. Thank you.
My colleague, Dr. Zhang Lin, did 3 cases in Wuhan. For these 3 cases, one is recovery now, and the other one is with the heart stroke, heart failure. So it's not successful. But the cause just for the heart failure. And the third one is still on the treatment. Is on the still in the ICU. So based on his personal opinion, just limit data, his suggestion is helpful, but there are some limitation.
So I just want to ask one more question about bronchoscopy. Do you have any experience that the radiographic pattern, presence of crazy paving in the presence of hypoxemia, those patients may more benefit from lavage than other patients that don't have crazy paving? To make a decision by using the HRCT, what patients may benefit from bronchoscopy from a therapeutic standpoint rather than diagnostic?
We don't have the experience about this kind of patient because the crazy pave signs in the CT, maybe the patient have high fever, and maybe sometimes the patient did not have the very, very severe dyspnea. So sometimes we perform the bronchoscopy in the patient with the intubation. Most of them, I think, yeah.
Yeah, from our groups, I think most of the patients actually perform bronchoscopy during ECMO. So it makes it safer, and it makes it so to prevent from further hypoxemia. So that's why, and I agree with that. So some of the patient had acute obstruction of the airway. It means some of the mucus have some causing obstruction of the airway. So at this situation, we use that. So that's had a limit indication. I agree with that.
A group led by Henri Colt and others has put together an online database so that if people are performing bronchoscopy on a COVID patient, to put in various characteristics so that as a group, a world, we can all try to learn, maybe similar to what Jerry just asked, if there's any positive event that can come out of bronchoscopy, or more importantly, who we should never do it upon, so that we can be at least more nuanced in our pro and con about bronchoscopy. So I'll throw that plug out, but that's available online.
Yeah, I agree with that. So we can make a protocol and have a multi-center investigation on that. Yes, agree.
Well, there are questions about COVID-19 in pediatric patients. In the early Chinese data, it seems that the COVID-19 did not causing severe problems in kids. However, in some of the U.S. pediatric patients, some died from the disease. Is there any difference regarding virus in U.S. and in China?
We don't have children in the Red Cross hospital when I stay in Wuhan. But I asked some patients, they have grandchildren and maybe have fever for 1 or 2 days and recover soon. So, but I don't know if there's still virus in the children and can transmission the disease to others or not. So it's very important. I think it's worth to investigate this issue. Yeah.
I have a glance for the one paper that's coming from Wuhan. So reporting 48 patient children being infected with COVID-19. So I didn't looking at the reading it in detail, but she told me so only say like 2 to 3% of the children got serious ill, and the symptom appear to be some of them to be digestive system, diarrhea, vomiting, and so on predominant. That's what I know. But the majority of the children are generally mild, easier to recover. That's what Yes, please.
Is there any evidence that children with asthma are at a greater risk of developing lung pathology associated with COVID? Do they progress further than?
That's a good question. So I think we are now collecting some data about that. So in those with atopic and allergy patient who is more prone to have COVID-19 infection or not. So our primary investigation showing the opposite. So the majority of the patient actually they have a lower eosinophil count when they getting severe. In the end stage of a patient, so usually they have leukopenia and also very low count of eosinophil. And this is what we are going to look at. What is the relationship in between atopic and the suspected of the COVID-19? Very interesting question. So the result will be coming out soon. And then one is something like the eosinophils. Another one, of course, the cytokine storm. So IL-6 in some increased tremendously in some cases. So in that case, we probably use tocilizumab in those cases. So the result will be coming soon in and more than 100 patients receiving tocilizumab. So it's compared with the control group. So will be coming in next week.
So when you use tocilizumab, do you measure IL-6 levels to determine to use that or not, or you use just the clinical information that you have?
There are some arguments in China. So in some of the data coming from Anhui province, they suppose all the patients they had measured the cytokine spectrum in their serum, and in the only is an indication for those patients who have a higher IL-6, the highest IL-6 is the indication. But some of the other center they just use IL-6 receptor antibody, tocilizumab, in those who have cytokine storm. So we are trying to see what's happening. So later on, so the result will be coming out.
That's good. How about the use of systemic steroids or macrolide antibiotics, or and your views on remdesivir?
I suppose steroids still remain an argument about that. But in our institute, we only use corticosteroid in a serious ill patient who have a progressing situation in a short time. Look at say like toxic effect or some others. Perhaps Dr. Law will give us some comment. But from our experience, we only use in this kind of patient only 3 to 5 days, not more than 1 week, by using low dose. So 2 to 4 milligrams per kilo. So each day, so 3 to 5 days, and then we then stopped, because we have found some of the patients who are on the steroid for more than 2 weeks. I think when the steroids was withdrawing, so the situation is getting worse, and in some of the cases, the virus shedding is prolonged. So I don't think that's a right choice for longer use of corticosteroid to so-called to treat the patient with cytokine storm.
Okay, I want to come for steroids. In our ICU, we have 13 very, very critical patients. The lowest pulse oxygen saturation is almost just 35. And we tried large dosage of steroid for this kind of patient. And the largest one is that as higher as 500 milligram for 1 day. And it's the same. It's just like what Professor Zhong said, that just 3 days in this kind of patient. And we have 8 patients survived from the treatment with the non-invasive ventilation with the large dosage of the steroid and discharged from the hospital. The survival rate is very high, I think. Yeah. But one patient died from DIC and also the infection, blood infection shock. And so we just use the steroid in a short times, 3 or 5 days. And in the patient with rapidly progressed dyspnea, and also the CT progress very fast within 3 or 5 days. For example, the lesion increased maybe half and also 1/3 compared with the several days ago. So we use the large dosage of the steroid, I think. Especially in sometimes you don't have the condition to perform the intubation, you can try this one, the large dosage of the steroid with the non-invasive ventilation. So we still summarize the data. Okay.
So
Right.
actually, we used the corticosteroids only in the patients who had developed septic shock. We used hydrocortisone 200 ml per day.
I think there's a disagreement with the doctors from ICU and from the respiratory department. In the physicians from the Department of Respiratory Disease, like to use the steroid, but the physician from the ICU agreed to use the steroid. Yeah, that's different.
Yeah. Have you found any value with the use of macrolide antibiotics like azithromycin or clarithromycin for its anti-inflammatory effects at all in your patients that you've treated?
Not yet. So I suppose in the States, you try that. So we haven't used that. So far as I know, I have no experience. We have no experience about that. No clinical practice. No.
How about remdesivir? Have you had any good outcomes with use of remdesivir?
Excuse me. So
remdesivir, antibiotic.
Yes, remdesivir will be coming out. So very soon. So because there's a randomized, very strict placebo control study will be coming out. I think in the next 2 weeks. I think it works in some way, but in some of our local data, but not specific. So the so-called target treatment. So from our in vitro study, this shows some efficacy. So it seems to be quite good in terms of the antivirus activity.
Good.
So
this is Mark Rothenberg. If I could say a couple of words. Is that right, Professor Lamb? Can you hear me? Am I?
Yes, we can hear. We can hear.
Well, I just wanted to take this time to say hello, Mark Rothenberg, Cincinnati Children's Hospital. On behalf of my colleagues, 2 of them are in the audience, Dr. Lara Danziger Issakoff, as well as Jeff Simmons, as well as Bruce Arena, who's on this session here. He said a couple of words. I want to thank you for letting us participate. We're over here at Cincinnati Children's Hospital, which is in the state of Ohio. And so we saw in the slide earlier, Ohio is still relatively modest level of total cases. Cincinnati Children's is probably the second largest pediatric hospital in the U.S. And we've done a lot to prepare in the last 2 weeks for COVID exposure. The whole workforce has been shifted around, and most of the hospital is working from home. Hospital census is low. We are prepared for taking care of patients, and we've really done a lot of changes, particularly instituting telemedicine to manage our large patient volume. But of course, critical issues in the hospital continue. We still don't have any positive patients for COVID. We're expecting to see them. Some of our adult hospitals have encountered them. So participating in this conference today has been very informative and enlightening, and I thank you for allowing us to participate. I myself are very happy, or at least I have some light in the tunnel to hear the results that you've seen in China, and I appreciate you sharing the information, particularly about the epidemiology. It's encouraging to see the disease has basically been put under control due to the measures you've taken in China. And I'm also personally inspired to see a conversation like this taking place with so many people coming together, communities and nations working together. And I think this is very key. And this epidemic shows us how the globe needs to work together. And the globe is really a small place. And what goes on in China or another country is very important for each person in the world. And we need to work together into governments to understand that. I'm impressed to see the amount of research going on. Thank you for so much for uncovering so many interesting points that are going to help us with our epidemic in the U.S., which is now going to be quite large, and it's very devastating from what I could see. I appreciate the science, and I think this is very important, and this epidemic motivates, I think, all of us to think more about these threats that we have and the future, which potentially will be threats from other infectious agents and, of course, other medical problems that could emerge rapidly. And this is something that we never really thought on a personal level that we would experience, but it's one that we've seen before, but never at this magnitude. As you may all remember, the 1980s, and an HIV threat to me was the biggest threat in my career. You know, when I was training and when we thought that HIV was going to really take over the population. And of course, it affected too many millions of people, but we do know through science that we controlled it, and it is a livable disease now. And that's the victory of science. And I think we're going to have some victory here, not through social behavior mechanisms, but also through all the research that's ongoing and the clinical trials that you guys have started will help us and then hopefully control. As you know, there's a number of vaccines and innovative trials, and the anti-IL-6 is looking promising for those patients that appear to have this cytokine storm. I'm also excited to see the future collaborations that hopefully will emerge from this. And I look forward for our group at Cincinnati working close together with you, but I hope that it won't be limited to that, but we can engage many nations to work together, at least on health-related issues, and that could spur into other areas. I also think that this is an opportunity to stir new minds, particularly young people. Here in the United States, a lot of people are no longer going into medical research. It's not as attractive, but I think this type of experience really does take new minds and stimulate them, and hopefully we'll see some new people and a fresh set of young people that will be going into medical research so we can deal with this. Wanted to remind the group that, you know, in 2003, SARS was present. It was very similar. It was much smaller in magnitude, but the pathogen was very similar. It had similar effects in the lungs from what we can see, and the actual genome was quite similar. It was about 83% identical to the current genome. And a lot of the lessons we learned from SARS could have probably been more applied to save lives today if we would have taken that probably more serious on a global level. And I think to make sure we don't make the same mistake with COVID-19, so that we can really use the information we're gaining here to help people going forward. Just wanted to end, and again, thank you for allowing us to participate today. Wanted to just turn the conversation, if you don't mind, into a couple of questions about the immunoglobulin serology testing. You showed a dipstick that was positive. I wonder what your true experience with that, how reliable you think it is, and if you've looked at IgG levels particularly in the Hunan medical workforce, to see what percentage of the people who are working with the patients were seropositive, and if you envision using a seropositive workforce going forward here in the U.S., and you think that would be valuable as a front line for this treating this disease?
So you are, am I right? You are asking the treatment using IgG, so immunoglobulin, is that right? Or
I'm asking to find out. You showed IgG strip test, IgG and IgM on a dipstick, it appeared to be. And there was a lot of positives. You said people were positive for the antibody.
Yeah.
Right?
Yeah, yeah.
I was just wondering if you believe the test, how good the test is, that dipstick. And do you believe that the people who work with the patients have a high rate of the IgG positivity? And should this be used to screen the workforce to employ them to take care of the urgent need in various countries now, the US, for example, but in other places where we could actually take the seropositive patients and presumably, you know, they are relatively strongly protected against the infection and could be the frontline workforce for the epidemic that we're now encountering.
Yeah, yeah. I think at the moment, the WHO just work out and document and just try to give a general survey in the people to see how high or what's the positive rate of IgG. So but on the other hand, I suppose in those who are healthy person who have a higher IgG, they can use as a donate for the IgG treatment for this serum treatment. Only in those patients who recover from COVID infection. So actually, we're on the way doing that. It shows a really good result, promising result. So I think you are right. We need to have some data, IgG data, IgM data, and see how much the prevalence or the incidence of the patient of the human being, of the subject being infected with COVID-19. That's very important for us, for epidemiologists, to have a prediction of the outcome of this kind of disease, whether it will become a routine influenza or some others. So that's important. You're right. Well, and just one point, as you are pediatrician. So the quarantine, the home quarantine, I think it's available in the States, because in the States, it's not different from China. So people living in a very small room and without any too much room for that at home, so that the home quarantine is not available in China. However, in the States, in majority of the home, you have the apartment or some others. So home quarantine is important, but actually should be paying more attention to the close contactors. So I think if in the States, the close contactor will also receive some check-up of the RNA, PCR. I mean, and then find out the positive rate and then make isolation. That will really useful in cutting down the increasing rate of COVID-19 infection.
Can I ask Can I ask a question? I'm sorry, Dr. Bing.
Maybe I can. Actually, regarding Dr. Rosenberg's previous question, I had a chat with Professor Law, because he led a team work in Wuhan for 2 months, and asked whether they checked the antibody in his staff, what is the percentage of positive IgM and IgG. It is actually extremely low. For asymptomatic healthcare workers, they do not have antibodies. So basically, I would assume for this new virus, if you get contact with the virus, you will have symptoms eventually. Therefore, I don't think we can use this method to find out who should be working in the dirty team. Although if they do have the antibodies, that would be good for them. If now we only have one strain of virus.
Yes, some staffs in the Red Cross hospital test antibody, and without the symptoms, And I think I don't have the full data, but I think it's very low, because if the positive, they will ask me to help. So because I stayed in the Cincinnati Children's Hospital for 1 year, so I suggest Mark to ready for COVID-19, because there's so many patients in the children's hospital, and the fathers and mothers come in, and so you should be careful and ready for this disease. It's my suggestion for Mark. Okay.
Thank you. Yes.
Can I ask a practical question on something of even more of a limited resource than ventilators, and that's ECMO? It's been discussed and talked about, and I'm curious, was there any anecdotal evidence of a specific clinical parameter or type of patient that potentially benefited from ECMO versus ECMO being just simply a bridge to nowhere?
So actually, we performed 15 ECMO already in my department for the COVID-19 patients. So from the all appearing if the patients with the low level of the lung compliance and persistent high level of the carbon dioxide, this kind of patient probably not recovered, from the ventilator. Even the patient can, it's difficult for the patient withdraw from the ECMO, because
Right.
that situation predict, the probably the poor injury of the lung.
Right.
Well,
Okay.
in our ward, we suppose if we have a fully used of a ventilator and enough PEEP and all the enough volume, but carbon dioxide still going up. That's very important indices for us to use ECMO. So not too late to use that. Should be earlier. So that's what we suppose. So we should not use that until the patient develop the MOF. No.
Okay. Thank you.
What percentage of patients who had really severe lung damage and were needing a lot of PEEP and intubated would progress to or multi-organ failure, particularly heart failure? My impression is that it's not as high of a percentage as we're seeing here in the States. Is that possible?
We have no any exact data showing that. So heart failure, so in autopsy, so the heart didn't show too much specific change, pathological change in autopsy. So, but some of the patients with hypertension or some other underlying heart disease, and of course, that's a very risk factor. So, to get serious ill. As far as you asking the percentage of serious ill patients concerned, so it varies from areas to area. But so in my knowledge, maybe at least 5 to 8% of the patient will get in serious ill if they had not received enough medical care in the early stage.
So actually, in my department, about almost 20% of the patients in ICU complicated with the heart injury. So the most common problem is the acute core pulmonary. I think it's probably induced by the hypoxemia, induced pulmonary hypertension, and then subsequently induced the acute core pulmonary. And for that situation, so if we give the very good oxygenation, and will be improved very quickly. And also around 30% of the patients develop the arrhythmia. Most common is the AF.
Okay.
Can I share something? Before, I think we are already overrun. I'm from Hong Kong, again, like Dr. Lam, and just before this, probably we need to end pretty soon. I just want to share a few things for the colleagues here. Just an overview of some of the things that we are learning from Hong Kong, from Queen Mary Hospital, from the University of Hong Kong, and of course, our experience in Hong Kong pales comparison to those in China. But a few things that probably echoes a little bit of what everyone has said here and there. The first thing is I noticed that a lot of the colleagues here in discussion today are basically skipping over Coletra because of the negative study. I understand that, but just to share my view, Coletra, it's in itself a pretty weak drug on its own. And the Coletra study itself selected a pretty sick candidate to start with. And I think there are pretty interesting results coming with, that would come out with Coletra with ribavirin with or without interferon. That I think there are some and more encouraging results that might come pretty soon. So there might be some other options for this, for the treatment of this. And in terms of the ACI, ARB, I know there's no answer out there, but I think there were initial data back in 2003 SARS that ACE2 is protective as a substrate. And so even if we have data, epidemiological data showing that ACEI or ARB uses are slightly higher in terms of mortality, it doesn't necessarily need to translate to stopping ACI and ARB for these patients. I think we need to tread very lightly on that. And I think the third thing is that's something to share in especially practical where everybody is short on PPE, something that we are doing in Hong Kong now, both in terms of screening patients, also preventing one patient possibly cross-contaminating, cross-infecting another patient during bronchoscopy, not for COVID patient, but basically one patient and then another patient, is that we're testing deep throat saliva. There are very early data from our microbiology colleagues. I'm sure they're collecting more, but if we do the deep throat saliva right, it seems that the sensitivity and specificity is probably comparable to an NPA, and the patient can do it themselves. So the nursing staff and the healthcare worker doesn't need to waste, well, not waste, but they don't need to use up their PPE or their N95 mask to help the patient collect the deep throat saliva. And that seems to be quite promising if they do that right. And I think that would be important comes a day when we need to screen a lot of patients. In Hong Kong, at least in the public sector, and I'm sure Dr. Lam can also share a bit in the private sector as well, we are lucky in a sense that we started out with a lot of, because of probably our experience SARS, we donned on masks very, very early on, and we did a lot of social distancing. So we suppressed the numbers pretty low in the early stage. I think without very accurate epidemiology statistics, our effective reproductive numbers, if we rule out those coming back just from local, it's something like maybe 1.6 to start with, and then 1.1, maybe some period even lower than 1. But then now, even though we are just starting to pick up again, remember we are handling maybe 5 cases of suspected cases that turns out to be not COVID, and for 1 cases, and those still uses up a lot of PPE. So I think we are running down the path of running out PPE and N95 soon. So I think this deep throat saliva screening tool thing might be something that at least in my view, could be quite promising because it saves up something that we cannot replace by just brute force, we working harder. We cannot simply magically pull N95 out of thin air. So that's just something I want to share.
Thank you, Dr. Tam, and thank you all for joining this webinar and for the valuable input, opinions, suggestions. So this concludes the event. I hope you're all in good health and looking after your patients. Thank you all.
Thank you.
Thank you so much.
Thank you for organizing this, and I'll give a thanks out to our friends at Broncus who put it together. So thank you for underwriting this.
Right.
Thank you, Broncus. Thank you.
Thank you to all our colleagues. Thank you.
Take care, Siwa.
Take care.
Well.